Thanks, George, and welcome, John. John and I have debated this many times, and we're going to make this a warm, collegial debate, but we'll have a little bit of fun as well. So, John, I'm sure that you represent some of the cardiac surgeons that just still can't admit that there's an alternative to cardiac surgery, that PCI has been around now for coming up on 4+ decades, and that it is a valid alternative for many patients with coronary disease. And today we're going to look specifically at the large number of patients with left main disease in whom I would argue that PCI is not only an alternative, but is actually preferred. So I have no specific financial interest with any stent manufacturers that might affect this talk. So this is not debate. This debate is not about you. It's not about me. It's about the patient. And we always want to do what's best for the patient. And we all agree that we should be thinking of these decisions in the framework of a heart team. That is, general cardiologist, interventionalist, and surgeon putting their hearts and minds together to make the best recommendations for the patient to propel the patient to their goals. And different patients may have different types of goals of what they want to get out of their medical treatment. So what do patients want? Patients want to live longer and feel better. Okay, so that's really it. It's really that simple. Live longer and live better. So what outcomes matter most to patients? And often they're different than the kinds of outcomes that matter to doctors. If you look, there are many surveys like this. Doctors think that death is by far the worst endpoint you could possibly have. Large MI and stroke are then probably half as important as survival. And then there's lesser outcomes such as revascularization, rehospitalization. But when you ask patients with heart disease, you get a different picture. They find that large myocardial infarction and stroke are at least as important, if not more important, as a, quote, hard endpoint than mortality. And they agree that these other events, while still important, are of lesser importance. So let's look and really focus on these three important endpoints. So I think that obviously no discussion about left main PCI versus surgery is complete without discussing the Excel trial, because this is the most contemporary, largest, international, comprehensive randomized trial, the largest to date, the only one powered for the triple composite endpoint of death, MI, or stroke. And John was involved in the leadership team of Excel, and this was designed by about 100 academic physicians, 50 surgeons, and 50 interventionalists, and some non-proceduralists. And we randomized a total of 1,905 patients to PCI with a contemporary Zion stent versus bypass surgery with a primary endpoint of death, MI, stroke at 3 years. And it's important to note that we had intended to include only low and intermediate syntax scores, but actually a quarter of the patients had high syntax scores by core lab analysis. So this was a fairly reasonable representative population. And the primary endpoint was at 3 years, but we followed the patients out to 5 years. So here's all the data. And you can see that overall, there was no major differences in this primary composite endpoint of death, MI, or stroke between PCI and CABG. And that's really the take-home message from the Excel trial. This was the only endpoint that it was powered to show. It was powered at 3 years and it was powered at 5 years. But it's important to note that these curves are crossing. Okay, so how do you handle crossing curves? Early on, there were fewer events after PCI, and then the curves caught up so that at about 2.5 to 3 years, after that point, there were fewer events after bypass surgery. So the area between the curves is really the difference in the exposure that patients have to the events. And you can kind of, if you're going to have an adverse event, you'd rather have it late than early. If you have it early, you're exposed to it for a longer duration of your life. So you can calculate the event-free survival time, something called restricted mean survival time analysis. And when you do this, at the end of the 5-year follow-up period, the event-free survival time was 5 days better with PCI compared to CABG. But you can see the 95% confidence interval, minus 46 to 57, clearly not a statistically significant difference. So the overall exposure to these three major events was very similar after PCI and CABG. Now that's really it. That's what this trial is powered to show. So if we want to start drilling down and we want to start looking at more low frequency endpoints that Excel and other individual trials weren't powered to show, this is when it's helpful to look at the totality of the data and the evidence that's out there and not cherry pick, but look at all the data. So patients want to live longer and live better. So is mortality different? So there's been 5 randomized trials of drug-eluting stents versus bypass surgery. This is the latest meta-analysis. This is the overall mortality difference. And you can see there is no difference. The relative risk is 1.03. The p-value is 0.78. You can see that there was a little bit of heterogeneity between these 2 studies, between these 5 studies, and that's that I-squared value of 42.9%. And the heterogeneity, when you see that, you want to say, well, which of the study was the outlier? Where was the heterogeneity arising from? And it was actually from Excel. And that's because of this difficult to explain increase in non-cardiovascular deaths in Excel. When you remove that, the I-squared value is 0, and the hazard ratio or the relative risk is 0.93. So that's how you look at these data. Now, some will say that 5 years is not long enough follow-up. You need to go out to 10 years because that's when the benefits of surgery are really going to emerge. Well, we have 2 of these trials that have gone out to 10 years, the syntax left main and the pre-combat studies. And you can see these are even with first-generation DES, not second. And you can see that there's absolutely no difference in survival at 10 years between these 2 studies. Curves are superimposable, and they're not at all spreading between 5 and 10 years. So, do patients live better? Well, let's start with stroke. Stroke's probably the second most important event rate. Are they different between these procedures? Well, if you look at the 30-day stroke rates, they clearly are different. Nobody would really doubt that. You can see that there are about 2/3 reduction in stroke with PCI compared to surgery, p-value of 0.007, no heterogeneity between these studies. But I do want to point out in fairness that these rates are low. It's 1.1% with CABG and 0.3% with surgery. So even though this is a debate, I don't think you should make too much of this. Yes, PCI has lower stroke rates, but it's only about an absolute 0.8% difference. At 1 year, that stroke difference is still there. You can see a 62% reduction. When you go out to 5 years, now you don't see an overall difference in stroke in the meta-analysis. But again, now we see a lot of heterogeneity. And why is there all this heterogeneity? Well, the heterogeneity was from the Noble trial because there was an inexplicable increase in stroke between 1 and 5 years in Noble after PCI, which didn't make sense. When you remove the Noble trial, now you've got no heterogeneity left, and you can see you've got a 42% reduction in 5-year stroke. But the difference in event rates are low, so I don't want you to make too much about that. What about myocardial infarction? No overall difference in myocardial infarction rates at longest follow-up between PCI and CABG, but there is a difference. The procedural myocardial infarctions are reduced with PCI, non-procedural myocardial infarctions are reduced with CABG. So there is a difference that we need to tell our patients about. And then finally, they want to live better. So is quality of life different? Well, I could show you a lot of quality of life data. In terms of relieving angina, this was the formal quality of life sub-study from Excel. Both therapies are extremely effective at relieving angina. At 30 days, actually, PCI was a little bit more effective than surgery, but I suspect that's because some incisional chest pain is being misclassified as angina. But by the time you get to 1 year and 3 years, both therapies are terrific at relieving angina. You can see the patients, this is the SAC angina score, it's like 95. They're essentially both groups are asymptomatic. But when you look at the physical recovery, there's just no doubt that surgery is tough to go through. And if you look after PCI, the patients are immediately feeling better, and that continues. After surgery, within the first month, they're feeling worse. Okay, it's a lot for a patient to go through surgery, and every study shows this. By 1 year and then 3 years, there's a catch-up. But this is, of course, why many patients would prefer PCI, because it's difficult. And we quantified this as related to major adverse events within 30 days that the surgical and interventional leadership agreed were important events, that reflected what happens in the periprocedural period. And there's a 72% lower rate of these major events after PCI compared to CABG. Not only less stroke and MI, but less TIMI major and minor bleeding, transfusions, AFib requiring anticoagulation, second procedures, renal failure, sternal wound dehiscence, sepsis, prolonged intubation, et cetera, et cetera. So surgery is a great life-saving procedure, but let's admit that it is tough to go through for many patients. So if you're evidence-based, if you are honest and you want to put patients first, you have to describe the pros and the cons of surgery versus PCI. And yes, there are some patients that are clearly going to be better for surgery, and there are some that are clearly going to be better for PCI. But I would argue, based on the totality of the evidence, that for left main revascularization, the data support PCI in most cases. Thanks very much.
So I'm assigned the topic that coronary bypass remains the best therapy for most patients with left main stenosis. And frankly, I think my job is not so hard. These are my disclosures. I think most importantly is that Gregg is my friend and colleague, although we don't agree on everything all the time. He did give me this really nice tie, though, which is my personal favorite tie from TCT 2016. I'm wearing it today in his honor. It is a conflict, I guess. It's a very nice tie. So he and I actually had this conversation already 4 years ago. And my assigned topic then was that XL and Noble proved that PCI is still far from an acceptable alternative to coronary bypass for left main revascularization, except for a small proportion of patients. And Gregg showed this slide, but there are a couple things that are important to point out. The XL trial was intended to enroll 2,600 and enrolled 1,900 patients, and followed them for the initial primary endpoint of 3-year follow-up for just a minimum of 2 years, which is far too short to demonstrate differences between coronary bypass and PCI. And I want to demonstrate that many patients were excluded from the XL trial and put in a registry, 2/3 of whom ended up having coronary bypass. So when we extrapolate results from a clinical trial, we have to think about patients who were excluded from that clinical trial, because of course in randomized trials, the bias is at the point of entry, since randomization eliminates bias thereafter. But the bias nonetheless exists at the point of entry, and you can see that 2/3 of patients who were excluded from the XL trial ended up having coronary bypass. That tells you something, and I was struck by the fact that that's a very similar proportion here. This is the coronary bypass, this is the coronary anatomy for the left main group of the Syntax trial, and you notice that 2/3 of the patients in the Syntax trial who had left main disease also had either double or triple vessel disease. I don't think that's a coincidence. Now, in the XL trial, 1.9 lesions were treated per patient with PCI, and there were 2.6 conduits per patient in coronary bypass. So I can't escape the conclusion that we had a more complete revascularization in the CABG group. However, we failed miserably in managing our patients with optimal medical therapy post-op. You can see that a large majority of patients had dual antiplatelet therapy in the PCI group and not in the CABG group. At 3 years in death, stroke, and MI, you can see that there are no significant differences for each of those components of the composite primary endpoint, but that there was a trend in favor of CABG for death. You notice that the MI, of course, is even at 3 years, but that's an important concept that we go into a little further. Ischemia-driven repeat revascularization and all repeat revascularization were strongly in favor of coronary bypass. Now, Gregg has shown the slides where the two curves cross, and indeed, the biggest deficit for CABG compared to PCI in the left main group occurs in the very first days. And thereafter, from 30 days to 3 years, you can see that death strongly favored CABG with a p-value of 0.02. The composite endpoint favored CABG with an endpoint of p-value of 0.02 and death at p-value of 0.06. And MI strongly favored CABG by about twofold. So I showed this slide in 2017. These were the 3-year data. And I asked the question, which curve would you rather be on? Because there was much heralding of this as showing no difference, and that there was a big green light on to do PCI for left main. But again, I ask you, which curve would you rather be on? And what would those curves look like at 5 years? Would they look like this? Is this the future of XL? And I asked myself, what would the difference be at 5 years or 10 years? Because those curves reminded me of this slide that Dr. Fuster gave me from the Freedom trial, where initially in the first 2 to 2.5 years, there was no difference between PCI and DES, with DES versus CABG in diabetic patients, but by 5 years, those curves diverged and continued to diverge more widely. And the Syntax trial at 1 and 5 years made the conclusion that CABG should remain the standard of care for patients with complex lesions. And again, I remind you that 2/3 of patients with left main disease also have double or triple coronary disease as well. So this is the JACC paper from 2016, the five-year data from Syntax, concluding that treatment with PCI versus CABG was an independent predictor of cardiac death, and this related to myocardial infarction. Now, in 2019, we, and I mean that literally we, Gregg and I and many others, published the 5-year data for the Excel trial. As he mentioned, and correctly so, the largest, most definitive trial of CABG in left main, and he deserves a huge amount of credit for getting that across the finish line. But I did have some important concerns about how those data were presented, particularly regarding mortality data, the publication of the pre-specified periprocedural MI definition, and the statistical analysis at 5 years, which was different than the one we performed at 3 years, switching from a non-inferiority to a superiority analysis. At 5 years, there is an excess and accelerating mortality for PCI. Again, these are relatively low-risk patients with age only 66 and a low to intermediate severity syntax score, but there was a relative increase in risk of 38%, and this was driven by non-procedural MI. Of course, repeat revascularization was also increased, and as Gregg did mention, there was no difference in stroke at that point. So some others have taken the liberty of looking at the Excel trial, excluding periprocedural MI, treating it the way the authors of the Noble trial did, and dealing only with non-procedural MI. And if you do that, then CABG becomes a clear winner for the composite endpoint and for the individual components of death, non-procedural MI, and repeat revascularization. So, the definition of myocardial infarction had a huge role to play in the conclusions reached about the composite primary endpoint. It took over 5 years to reveal the data for the international definition, universal definition of myocardial infarction, demonstrating that for procedural MI by the UDMI, there was actually a preference twofold increase in favor of CABG over PCI, and similarly for all MI, about a twofold increase. So had we presented the data with both definitions, we might have had a different conversation for those first 3 to 5 years about the meaning of XL. Ultimately, Gregg and others published this in JACC quite recently, clearly demonstrating that actually the relationship between myocardial infarction and PCI and CABG was about twofold by the SKY definition and about twofold the other way by the UDMI. And again, I think that myocardial infarction is most important because it impacts mortality, not because the chemical definition has a special meaning, but because it impacts mortality. We counted mortality, and I think that's obviously the most important endpoint. But this kind of understanding, I think, would have produced a more nuanced conversation about left main stenosis. And Gregg actually recognized this in a previous publication. This is a state-of-the-art review from 2015 in JACC, arguing that the most frequent and often least clinically relevant components of a composite endpoint tend to be the driver of events, especially enzymatic MIs. And frankly, that's exactly what we did in Excel. So finally, we looked at Excel with a non-inferiority margin at 3 years, a superiority assessment at 5 years. It would not have met the non-inferiority criteria at 5 years. And again, that would have been a different conversation. I'm going to skip through Noble because I see I'm running out of time, and Gregg covered it quite well. There was, in fact, a benefit of CABG over PCI from Noble, but not a difference in mortality. But if you take the Excel and Noble trials together, just those two, there's a relative risk in favor of CABG. This is an interesting paper. I don't pretend to be a Bayesian statistician. I read this with interest twice, didn't quite really understand all the mathematics behind it, to be honest, but did recognize the conclusion sentence that Bayes analysis suggested that whether based on Excel alone or the totality of randomized trials of left main disease, PCI was associated with inferior long-term results for all events, including mortality. So can we do stenting of the left main? Absolutely. Should we in all cases? No. And I actually differ with Gregg on just his very first comment, that I don't believe there's a role for CABG, for PCI rather. I really do. I believe we do too much CABG in the elderly and frail people, and I think we do too much PCI in young, healthy people who should have 3 or 4 arterial grafts instead. I think that's where we should be moving as a team, as a heart team. And this is an interesting article from New England Journal in 2005, explaining that the reason CABG beats PCI in many subsets of patients, especially those with complex disease, is because it protects against future myocardial infarction or future lesions that may develop proximal to the insertion point of the bypass grafts. So my last slide is there is an alternative to CABG or PCI for left main stenosis, and that's hybrid therapy. I showed one of these cases early on today. I think this is a great technique, especially for isolated distal left main bifurcation or trifurcation left main disease. And I think that this is where we should be heading for many of these cases. Thank you all for your attention, and thanks as always to Gregg for a great presentation and his ongoing friendship.
Great. Let's talk about why atherectomy is essential in calcified lesion revascularization, and let's see how we can give the main concepts of why it is that we see all the cases we see in the cath lab reviews of this year and every year in this great conference. First of all, the modification of the plaque is at the core of angioplasty from the very beginning. You can see how well the Dr. Grunzik had described exactly what happens to the plaque, that is compresses it and opens it and all that. So obviously the natural situation was that initially you needed to have a compressible plaque. And later on, when the plaques become harder perhaps, when we learn more, could we remove some of that plaque? And that's where the calcification comes in. And there's many ways to classify and categorize calcification. And we use the most practical one because all of us do fluoroscopy and cine angiography. If there's no radiopacity or faint radiopacity, we call that mild, not so important, easily to crack in any way. And the more moderate and particularly severe, the so-called tram track, when we have radiopacities in both sides of the vessel, these are really very important calcifications that may not give to a regular balloon, even high pressure balloon, and therefore we have some aspects of difficulty from then on. And you can see an example of the tram tracks calcifications. There is no dye in the left at the left panel, but you can clearly see the outline of the vessels because there's tremendous calcium, tremendously dense calcium, as well as long calcium. More sophisticated modalities using intravascular imaging in the center, the classic intravascular ultrasound, whatever is bright white, you see, and has a shadow behind it. You can't see really anything, is a typical calcium, very dense in this particular case. In the center of this cross-section of the vessel, you can recognize a catheter. On the right side, you see a very, very good imaging with the OCT, optical coherence tomography. Again, the catheter is in the middle. You see a tremendously clear interface between the lumen and the endothelium, and then you can see how a calcific plaque looks at the OCT. Obviously, you have to get accustomed to the black and white on the IVUS, which most of us are, I would say, and to the orangey tinges on the right side. And I think obviously those are obviously subjected to change and improvement over time. However, what it doesn't change, and no matter how many times you show this slide never gets old, because this is a fundamental reason why an angioplasty may have some problems. And we saw in the very last case, if you look at this graph, this is exactly what Dr. Kinney tried to avoid, that the left part of this stent right here, that was a proximal part, and that was really big. And she really wanted to be able to expand the stent without being impeded by this calcification. Was really a ridge right after this diagonal we saw. So you can see how this stent could be malapposed. Over here could be tremendously underexpanded, and who knows what we may end up distally, which essentially these are the dominant factors that if we are able to shave the calcium, we may expand this thing better, as well as allow this one to not be malapposed. And this is just an example. Why is it appropriate lesion preparation for coronary calcification important? I just show you also. And at the same time, let's say it's on your way to another lesion, your stent may just get banged left and right, as if you try to go through a narrow pathway with a nice suit, let's say, such as this one I'm wearing, and all of a sudden you get some dirt on your sleeve just because you're banging against the wall is very narrow. Same way the stent, you may get stripped a little bit. They're very, very important polymers, and the drugs eluted from them, and therefore you're going to have a geographical miss of the drug elution later on. Why? Because your stent device was banged and essentially inactivated in certain spots. In general, coronary calcium, particularly severe, this is a red bars throughout any event, and this is from very nice analysis from our group in the Cardiovascular Research Foundation. You can see that whether you're talking about death, cardiac death, stent thrombosis, TVR, MACE, whatever you want to look, calcified lesions, and patients who have them had worse outcomes in general. So not a great idea to have that. And this is from a population of unstable angina and acute MI. What do the guidelines say? What do PCI guidelines say about that? The PCI guidelines include various things. The cutting scoring balloon angioplasty has a class 2B, might be considered to avoid slippage during coronary trauma. PCI, for instance, restenosis should not be performed routinely during PCI. May be helpful by the EA PCI, may be useful in calcified rigid ostial lesions. I would say a weak recommendation, nonetheless, one that is existent. Rotational atherectomy is again not a very high recommendation, at high but not too high, class 2A recommendation for heavily calcific lesions. And in the EA PCI 24 statement might technically be required in cases of tight calcified lesions to allow the subsequent passage of balloon and stents, indicating the modification of the plaque. That's what this means. But again, it should not be performed routinely in de novo lesions or in-center stenosis lesions. No for routine, but yes for calcific, by the guidelines that always we know are very stringent. Laser angioplasty is included also in the guidelines for fibrotic and moderate calcific lesions. Laser is not mentioned for calcification in the EAPCI, the European statement of 2014, should not be used routinely again during PCI. And something that is not mentioned in the guidelines is that something we may see in another case, the so-called off-label utilization of the laser for the I would say for a heavily calcific nodule. And what we don't see in the guidelines is the the orbital atherectomy, because again, not enough data rise to that level. Nonetheless, they are possible. But this is, as you can see, very difficult to get the specific techniques in the guidelines. Nonetheless, they do exist, particularly for tight lesions as an adjunctive lesion preparation to pass the stent and the balloon. Let's go to the rotational atherectomy system. I don't want to stay too much. I want to stay to a relatively recent study, the Prepare Calc, a modified balloon with the scoring or cutting versus rotational atherectomy, and then followed up with the same type of stent implantation, let's say, so there's no difference there. And the outcome, the most important outcome, is that about 16% in the balloon had to cross over, whereas in the rotablator, they did not. And I think this is a technical study with a technical answer. 16% of time, if that's what Dr. Sharma is calling the rota regret. You regret you did not do the rotablator. How much is that? How often does that happen? According to the German investigators of the Prepare Calc, 16%. Not small. How about the orbital? What do we say about this other system that we saw and will see used in some of the cases? There are some differences. For example, the rotational can be used in orthosteals, whereas this is the orbital, maybe not. The compatibilities and all that, I think we discussed it over the cases. You can study it later. There is a review of cases that are not in any way any randomized, 8 observational cases indicating no difference in the overall MACE, etc. Obviously, these are different populations. No wonder this is a newer device. No wonder it's not in the guidelines yet in any way, because it's just developing results. Ultimately, what we really want to achieve is that you have a really good expansion of the lesion, as much as possible, a uniform stent expansion for whatever segment of the vessel you are treating. That allows the stent to atraumatically be inserted into the vessel, oppose well, and do its job by eluting the drug and preventing the restenosis. That is extremely important. When I was talking about the off-label use of the laser explosion, off-label, not in any guideline, you have a calcific ridge that nothing can expand it. You can see it right here. It's in the middle. Right here remains over there. If right there you do some laser passage of high energy and at the same time you inject a little dye at the same time, that includes a local bubble, let's say, that is possible. It's not recommended by inexperienced users and may actually help you. This is an algorithm for optimal management of coronary calcific lesions of just 2 years ago. And again, there is a lot to be said here. The balloon crossability is a very quick practical aspect. Balloon goes or doesn't go, very easy. And then if it goes, you predilate and you perform imaging, and then you follow it up with a very good predilation with a non-compliant balloon or a cutting scoring balloon, and you demonstrate the optimal balloon expansion. If you have a problem with that, or if you've already detected a lot of deep calcium by your imaging, then you go over here towards the atherectomy. However, if you're non-compliant balloon and ultimately the imaging confirms a good balloon expansion, you really don't need that. You may consider the lithoplasty balloon later. We can, as we learn more, this is another new device, not yet in any guideline, however available and expanding, I must say. If the crossability is no, that is the real problem now, because if you can't even pass a balloon that is deflated, how would you possibly? Then you try with a microcatheter. If it's a yes, then you have a chance with a rotational or orbital atherectomy to sort of go through the lesion. Obviously, no balloon goes, lithoplasty is not going to go. If it's no, you have a little bit of a situation, the direct wire with a rota wire, such as in this very last case Dr. Sharma indicated. If the microcatheter doesn't cross, but goes all the way to the middle of this occlusion and gets stuck at the calcium, let's say, you can still wire the rest of the occlusion most of the time with your dedicated atherectomy wire, and then you can convert to the atherectomy panel right here. If still the answer is no, in the very, very rare cases, Dr. Sharma quoted 1 over 1,000, it may be a couple of more than that, but regardless, you may have this, you may pull out of your pocket this laser bombing that I explained before as a general idea. And ultimately, you're going to end up reaching the optimal balloon expansion. All right? And then again, you potentially utilize the lithoplasty later to make it even better and all that. We don't want to go to all these details. But in general, you don't do the calcific, the calcific lesion treatment by trying to avoid atherectomy. You're going to regret it 16% of the time, and you're going to have unfavorable or non-uniform stent expansion and insufficient drug delivery in a lot more of cases. Let me leave it as such, and let me invite Dr. Ron Waksman to tell us all how we can forget a little bit of those things and just keep it simple for more of the cases. Thank you, Ron.
Thank you, George, and good afternoon, everyone. So, first of all, if you come to this meeting and you see these cases, you think that the entire world doing rotational atherectomy. So let me tell you, this here is anomaly. It's a good anomaly. And I actually congratulate Dr. Sharma and Kini for actually pivoting the rotational atherectomy, which I think should be done in much more of the cases. But if you have a clue how many of the calcified lesions are being treated with atherectomy devices versus what I'm asked to talk about, non-atherectomy devices, the ratio is probably 10 to 90. And the question is, why is that? Why we're not using atherectomy like what you're seeing here in this course, every other case? And the reason is that there are some complications. There is some complexity, although I don't buy that because decay crush is much more complex to do in atherectomy. But no one wants to see a no reflow phenomenon. No one wants to see perforations. No one wants to see bed dissections. And as a result of that, people shy away. They think that they can do it without it. So my goal is actually to talk about the others. And what are the others? Non-compliant high-pressure balloons, scoring balloons, cutting balloons, and lithotripsy. I took laser out of this because laser is still atherectomy for those who want to. So these are very simple things. And I would say the lithotripsy just entered into the market. But we really have to change the way that we are thinking. Now that we have all those devices and we're supposed to be better in atherectomy and with the RotaPro and the CSI system, we really have to go to some algorithm. Now, George showed you a very complex algorithm, and it took about 3-4 minutes to go over that. This is a simpler one. And the question is very simple. Can you pass a microcatheter? And I think he did mention that. But you can see that if you can do a stepwise inflation, escalating non-compliant balloon size. You can use scoring or cutting balloon. And then, only then, if it doesn't work, the new kid in the block, you can use IVL. And what I'll try to show you some data on IVL because it's not been covered much in this meeting. Now, this is much more complex algorithm. This was proposed by Dr. Schlomfitz from just across the island here. But again, what I'd like to take you, he does everything by OCT, which is also very important actually to understand what is the imaging tells you, and can the imaging guide you which device you would use. But if I'll just take you to the bottom of this slide, you can see here that on the very left, you see if it's a deep calcium, you can use a scoring balloon or cutting balloon. If you have a calcium fracture on OCT, you can use IVL. So there is one group that would use rotational atherectomy or orbital atherectomy. And these are when you have traditional atherectomy that's done in nodular calcium. When you have a superficial, it used to be just for atherectomy devices, but now we have data also that lithotripsy can work. And if it's a deep calcium, there's basically no role for atherectomy devices. You can basically use non-compliant scoring balloon or cutting balloon. And again, this is just an example of what you're seeing by imaging and what you can get with balloon that you try to get in a with a non-compliant balloon in a calcified lesion that you cannot open it. So let's discuss about lithotripsy, because this is really the new kid in the block. It is approved, and there is also reimbursement, or not complete, but it does help. So what is the lithotripsy? It's basically based on acoustic pressure waves that fracture the calcium. And these are traveling through the tissue with an effective pressure of roughly about 50 atmosphere and fracture both superficial and deep calcium. Now, if indeed this is working, then this system will offer you a very safe procedure, as was shown in all the trials so far, with no perforations, no dissections, no losing of flow. And it does give you assurances that you, in most cases, will be able to get the desired result. And it comes in different diameters and different catheters. We've been using it excessively in the periphery, which that's how it started. But when you look in coronary intervention of lithotripsy, you see a very good effect in enlarging the lumen after creating those fractures to a lumen area that starts from 2.98 on a heavy calcified artery all the way to a lumen of 8.15. The pivotal trial that granted approval by FDA was called Disrupt CAD3. Again, it was a registry. There were rolling patients and 384 patients that were in the intention to treat. And what was presented was only 30 days follow-up, which was enough to grant that approval. Now, what was the major endpoints? There was a primary safety endpoint, which was freedom from MACE at 30 days, cardiac death, myocardial infarction, target vessel revascularization. And there was primary effectiveness of the procedure, which was define a successful stent delivery with residual stenosis less than 50% and without in-hospital MACE. And then there was all the secondary endpoints. So this is the study algorithm. Overall, there were 431 patients in the study with the roll-in and the intention to treat. These are the characteristics of the patient. The procedure time was relatively adequate to a calcified lesion, nearly 60 minutes. The number of IVL catheters was 1.2, IVL pipe pulses 68.8, and the number of stents that were used was 1.3 with a very good stent delivery. So this is the angiographic outcome. You can see pre-procedure, post-IVL, and post-stenting. So you're achieving a very nice lumen. And in terms of angiographic complications, post-IVL, you can see that they were very, very small. There was zero perforation, zero abrupt closure, 0.6% slow flow, and zero no reflow phenomenon. And final post-stent was, again, no issues with any complications. So as a matter of fact, it seems to be very safe and also effective device to use. These are the primary safety endpoints, which worked through a performance goal. We wanted to have a randomized trial, but there was no randomized trial. But it did met the primary safety endpoints as shown here, and also the primary effectiveness endpoint. And these are the in-hospital 30 days MACE, which were very low overall, 7% at in-hospital and 7.8% at 30 days. And you can see here, very low event rate. These are the secondary endpoint with composite success rates of roughly around the 95%. It is very good for a treatment which is not atherectomy based, and it doesn't take much time and much pain to do it. These are some peri-procedural MI. They're also relatively very low. We see or tend to see more distal embolizations with atherectomy devices. And overall target lesion revascularization at 30 days was 7.6%, all revascularization 2.6%, and stent thrombosis only in 0.8%. There was an OCT sub-study, again, demonstrating that there is really a breakout and fractures of the calcium after using the acoustic waves. And overall, they summarized that they confirmed by OCT safety of the coronary IVL with no severe angiographic complication at the end of the procedure. And it's demonstrated longitudinal and circumferential calcium fractures, and MSA area stenosis and stent expansion outcome were excellent regardless of calcium fracture visualization by OCT. And this may represent a limitation of OCT to detect subtle microfractures in calcified plaque. But overall, I think we have to recognize we need to learn exactly how to use it. But if I have to make a prediction on this podium today, I would say that we would see much more of those devices being treated calcified lesions. It's not going to be on the expense necessarily of rotational atherectomy. We'll continue to use that. I'm sure that Dr. Sharma will continue to use it heavily. But for the other centers, they will use much more this lithotripsy because these are very promising devices. And I'll stop here because of the time. But again, when you go to the website of you'll see many other cases that shows and demonstrated the performance of this one, like in this calcified lesion. This is a very tight calcified lesions that has been treated nicely with the acoustic balloon as shown here. And this is after the last balloon inflation, and very good result. So my take-home message, there is still a role for the non-atherectomy devices. If you want to see how does it working versus the atherectomy devices, we will need randomized clinical trials. And I'm sure someone would do those trials against atherectomy, whatever it is, rotational or orbital, and will prove or not prove whether this device is safer and more effective. Thank you very much.